Professor VISHALI Gupta. She talk to us about going on to macular choroiditis, which is another issue, when, what to suspect and management. Nobody better than her in this country. And in case we have time, she can continue with the diabetic vitreous surgery because she has some material on her laptop because Rohan has not been able to come. Flight was cancelled.
Thank you very much, Professor Atul, for this great honor. And it's truly very nice to see all of you in person and not sitting in the study room and, giving a good talk on the computer. The topic that Dr. Atul has given me about macular choroiditis. What we need to know about choroiditis especially is that it's a very close call between infective and non-infective. Now, I'm showing you 3 pictures in 3 rows. The first one is APM-PPE, which is idiopathic. The second one is serpiginous, which is due to tuberculosis, and third one is a placoid due to syphilis. But if you look at these fundus pictures, looking at them, sometimes you really have to look into it to differentiate infection from non-infection. So what do you do when you have a patient of choroiditis in front of you? First, see whether it is choroiditis or is the retina involved too, that is retinochoroiditis. Secondly, look if there is involvement of the optic nerve head and vessels in the periphery. Thirdly, does it fit into any entity that you are aware of? Fourth, look for associated features. Is there vitritis? Is there scleritis associated with this? A CNV? Is it a single focus, multifocal? Is it unilateral, bilateral? Any systemic disease? Look at the past records that the patients are so proudly carrying with them, and you feel irritated because it is all a chaos, but they might carry a lot of information. So is it responding the way you want it to be responding? So how do you apply it in clinical practice? That's what I'm going to show you. Now this is a fundus photograph. This lady comes to us. She's a young 29-year-old girl. And history, she says, well, she's received intravitreal triamcinolone, oral corticosteroids, anti-TB drugs, and, not much improvement. So her vision is counting finger. Now, is it choroiditis or retinochoroiditis? Here, the retina is involved, and always take the help of OCT these days to see whether retina is involved or not. Well, it's retinochoroiditis. Is there associated vitritis? Yes, there was. Patient is immunocompetent. It's a unilateral disease. Now, why would TB present as retinochoroiditis? So you know that it's probably not TB at all. Now, very important, what was the past episode like? Now, this patient was actually carrying the photo which was at home and which we got later, and this is what it was when she first presented to the ophthalmologist. Look at this picture. This is retinitis, this is unilateral, this has fuzzy borders, and this has haze over it. Walks like a duck, talks like a duck, it's toxo. You don't even need any investigations. So, it's toxo, but this patient received multiple steroid injections, oral steroids, anti-TB, and that is how she ended up being like this. And of course, we did everything, and she even had toxocysts in her vitreous. But despite doing this, the vision doesn't come back because of the mess that has been created. The second is looking at the phenotype. Now, this is the phenotype which you have. Very classically, we have been taught peripapillary, finger-like, pseudopodia-like projection. Going in the centrifugal direction is serpiginous choroiditis, something that we honestly do not see very commonly. This is one of the very rare patients that we have. So this is when you see this, there is no vitritis. This is the classical variety of serpiginous choroiditis that would require steroids, immunosuppression. Though important, you may test for TB, but even if you don't, nothing major, because this is a unifocal disease and it is progressing at the tip. So the other variety of serpiginous is serpiginous-like. Now, I would give you an example of this patient, a 27-year-old male. He has choroiditis, he has vitritis, he has peripapillary involvement, but what you see is the multifocality. These are the multiple lesions, they're not unifocal, and there is associated scleritis, because I said in the beginning that you pay attention to what else is there. Now, the classical autoimmune variety of serpiginous would not have vitritis, would not be multifocal, and would not have associated scleritis. Once you have these three features in it, think of TB. So, fluorescein is very different. You can see this is IC3 of course, lesions are hypo to hypo, and when you investigate, sure enough, Montius is positive, quantiferon is positive, some lymph nodes, and we even did EBUS through the lymph nodes, which shows TB granuloma. This is how the patient responds to anti-TB. So very important that if you are seeing serpiginous in the center, differentiate between the serpiginous and serpiginous-like, because this is TB, R infective, this is autoimmune. TB-like tends to have unilateral disease, associated inflammation, either in the anterior chamber or in the vitreous, usually begins in the posterior pole. Like this one, the classical is juxtapapillary, the first patient I showed. TB tends to be multifocal, and then there is pigmented clumping at the center of the healed lesion. Serpiginous-like can have other etiologies. Everything is not TB, so please do not say that we just treat everything with anti-TB drugs simply because we are in India. No. There can be multiple etiologies. For example, this patient actually had VZV infection treated with antiviral. Syphilis is another one which can mimic, and this is the placoid choroiditis due to syphilis. So syphilis is something that you should rule out for all the choroiditis, irrespective of its shape, size, color. So this is post-antisyphilitic treatment. Then comes the multifocal type of choroiditis. So far I have spoken about diffuse choroiditis. The multifocal choroiditis itself can again be confusing. For example, this 57-year-old monoocular woman had trauma in the opposite eye, and you see some of these choroiditis patches, fluorescein, disc edema, some hyper somewhere. Peripapillary, I thought there could be a peripapillary membrane. There was disc edema, vitritis. So for want of anything else, we made a diagnosis of sympathetic ophthalmia because the tests were negative. So treated her with steroids, immunosuppression, initial response, and then worsening. So that was my point number 7, that if the patient is not responding the way you want the patient to respond, please look for alternate etiologies. Now this patient, if it was sympathetic, it should have responded to what we were giving. But if there is worsening, then what it is, repeat the test, repeat whatever it needs. Her Montius was positive, quantiferon was positive, and we even went to the extent of enucleating the blind eye, which showed a single AFB sitting there. So it was actually TB presenting as multifocal choroiditis, where the initial tests were negative, but on receiving immunosuppression and steroid, the test became positive. So it's always a good idea to repeat the test after 3 months or 4 months if things are not going the way you wanted them to go. So this is how she responded. This is the algorithm, that is the nutshell. Choroiditis, when it presents, it could be diffuse or it could be multifocal. If it is diffuse, see whether it is retinochoroiditis or serpiginous. If it is retinochoroiditis, there are two possibilities. It could be toxo, the example that I showed, or it could be viral. On OCT, toxo would always have underlying choroidal involvement. That will be retinochoroiditis. Viral will be purely retinal. It could be serpiginous, which can be autoimmune or which could be infective, and I have already highlighted the difference, how to differentiate the two. If it is autoimmune, you may investigate if there is no response to steroids, but you can actually start steroids. If it is infective variety, always investigate to rule out infectious etiologies, TB, viral, syphilis, before you actually initiate therapy. It could be multifocal, which could have a very classical phenotype. I haven't touched this point because of the time shortage, but PIC, MUDES, AMPI, very, very classical. Just start whatever you want to do. But atypical phenotype, like my patient with sympathetic ophthalmia had atypical phenotype. So always, always investigate before you treat. Thank you very much for the very kind opportunity, Professor Atul. Once again, a sheer pleasure to be present in person.
And we have 10 more minutes for your diabetic witness.
So I can give the diabetic, okay. Well, now switching gears from uveitis to diabetes, and I will give a talk which originally Rohan was supposed to give. My talk may not be actually complete, but anyways, I would just share what it is. We have young people sitting in the hall who would be doing or planning to do vitrectomies for diabetics. Before you take up the patient to OR, it's very important to have preoperative considerations, which includes good metabolic control. Professor Dogra highlighted that. Give preoperative anti-VEGF agent because it will help in reducing the intraoperative bleed, but always make sure that when you are injecting as a pre-op measure, your everything is under control. It's not that you have injected, planned surgery, and then your anesthetist or somebody takes BP is very high. Because if you are postponing the surgery after injection, the chances of development of a hole and combined RD would be very high. Pre-op PRP is another important thing. Wherever retina you are seeing in the periphery, please get a PRP. And if you are doing PRP and there is a traction, just stay away from the traction. Don't go too close to it. The key point in the whole diabetic surgery is just single, you identify the right plane. Rest all is a cakewalk, I must say. Choose a good machine and choose the cutter that allows you to work very close to retina. And we do have now bevel cutter 10,000. Honestly, 10,000 you don't really need most of the times, but up to 7,000 cutter, especially when you are working close to the retina. Now, this is one such example. In diabetics, of course, like any other surgery, you would do a core vitrectomy, make a good clear vitreous has to be done. Now this is the point. You want to enter the membranes at a point where it is away from the retina. And once you have the membranes, you just keep on insinuating. Here I'm using proportional reflux because I use that a lot, just to use and separate these membranes from the underlying vitreous and underlying retina. As you keep on separating, keep on cutting them, and then go to the next segment. Now, you can see here the patient is not bleeding much, and that is mainly because of the preoperative anti-VEGF and the laser scars that you may be seeing. As mentioned previously, Dr. Atul showed a beautiful video. It's important that you segment. You put them into multiple segments and then you can keep on peeling. For want of time, I will not go into the full, but you can see the pre and post. The third point, which is very important, is intraoperative control of bleeding. Unlike some other surgeries like vasculitic and all, where you can have the control of the bleeding even if you attend it later, diabetics are something different. This was just to show how you can use proportional reflux. But this video is just showing you that in diabetes, if you see a bleeder, it's better to tackle it there and then, because if you leave it for it to come back to later, you may have a fibrin, and fibrin acts as a glue. Now you can see here, there was a bleeder here which has been diathermized with beveled cutter. You can actually, you don't have to use a second instrument at all. I don't remember using second instrument, for most of my cases. You can use it for most of the things. You can go close to the retina, do the aspiration, take out this blood which is on the surface of the retina, and if you're a beginner, do the proportional reflux, displace this blood from the surface of the retina, and then just take it out. The identification of vitreous cases is the key step. Now this video I will just show you that you have done a good dissection, and you can see here a thick membrane which was dissected using a cutter, and there is a break here underneath it which you will see soon once the this thing is just below. This was a break, it's a combined RD. This is the break. So you have dissected the membranes nicely, and you think, well, I'm an experienced surgeon, I did a good surgery, so there may not be anything left behind, because honestly it doesn't show. So this is another node here which was taken care of. As you can see, we have taken care of, and by this time the retina looks fairly stable, as if you have removed everything from the surface of the retina. And then you inject then you inject Kenacort, which is very important, because many times this cases may not be visible to the naked eye. So I use either MIOCT or Kenacort, of course we all use. So use Kenacort and see this whole sheet of posterior schisis which was left behind. So this is one of the very important tips which has been said multiple times, but is worth repeating, not to miss schisis in diabetic patient. And the fourth one is MIOCT. Dr. Atul again showed beautiful microscope integrated OCT. You can use it to identify nodes. You can use it to make sure that there is a complete removal of the vitreous, especially if you are not in a mood to put Kenacort for whatever reason. So you can see here that after the clearing of the vitreous, we are using proportional reflux, which is basically used to create planes. And this is MIOCT guided. You have a node. You can see where your instrument is actually going and what is the distance between the retina and the node. So it can, it can guide you, but to be very honest with you, you can do surgery without MIOCT as well. If it's there, good. If it's not there, it's okay. And of course, you can detect the area of strong adhesions, and this one here shows a very nice vitreous schisis. You can see this is the schisis here. The vitreous is actually split into two layers, and when you are using OCT along with your intraoperatively, you can remove that schisis, and you can actually see, ensure that that schisis is removed, because you don't have to inject. Now here you can see this is the splitting of the vitreous in two layers, and you will see that towards the end you can cut it and you can actually do OCT again to see the retina is all. I think I'm running, this is the post-op to show that all that has been cut. And the fifth and the last one is that bimanual dissection always resort to whenever you are requiring it, because the bimanual dissection also, I will show you a short clip here. I don't think this is required. Now, this is the kind of the cases where you would need bimanual dissection because the retina is really very firmly adherent. Put MLS, and I generally use forceps, and I use my cutter still with proportional reflux to, with the other hand, to separate these dense adhesions from the underlying retina. Now, this is what it is. Once you have this plane and you have entered the right plane, the rest becomes easy. And you can of course use OCT, but to be very honest with you, when retina is really lifted and detached, focusing the OCT is not easy. Many a times you are seeing it clinically and then you ask your fellow to focus it because you want to show it to a meeting, but at times it does help as well. And sixth is, do we have time or I'm done? Sixth is for doing that plane, change the direction, shift to a side, because this is a video taken in between the surgery. I have removed all this and I was planning to go, but it's not comfortable. So come to this side, create a new opening through which you are comfortable and start working from that direction, because one particular direction peeling from here was not working. But when I entered from here, you can see the fibrovascular proliferation could easily be separated, and you can do the segmentation and carry on the surgery as before. So I think we have only 5 minutes left. So the video is running, that's fine, but I just wanted to make some points, and if there are any questions, I would be very happy to take for both the talks. And thank you very much, sir, once again.
Any questions for Professor VISHALI Gupta for a very nice 2 talks which he gave, or for any other presentation if you have?